Rabies is an acute fatal illness of the central nervous system with quite a variable incubation period of generally between a month and 2 months. However, it can sometimes be as long as 19 years and depends on the site of the bite. Bites at the extremities, such as the toes, which are the furthest away from the brain, will take longer for the virus to start causing clinical symptoms. There is usually some pain and a tingling sensation at the site of the bite. As the illness progresses, patients may lapse into a state of agitation, hallucination, and salivation, appearing to be foaming at the mouth. Many patients experience difficulty in swallowing, accompanied by the sensation of choking, giving rise to hydrophobia, a fear of water. Delirium and convulsions may occur occasionally, followed by a coma. Rabies has a high case fatality rate, usually 100%, if post-exposure prophylaxis is not provided in time. Half the deaths are due to respiratory paralysis. Dogs and cats can transmit rabies 3 to 7 days before clinical signs and throughout the illness, usually through bites or scratches that introduce virus-laden saliva from the infected animal into the human body. Rabies can also be transmitted by inhalation of droppings from infected bats. There are 2 transmission cycles of rabies. The urban cycle involves unimmunized dogs and cats, and the sylvatic cycle, wild skunks, raccoons, foxes, wolves, and bats. Human and cattle are dead-end hosts and do not transmit rabies to others. Rabies is a global disease. Countries that are currently rabies-free are usually island nations such as Australia, Japan, Hawaii, Taiwan, the United Kingdom, Ireland, and several European countries that have proactive rabies elimination programs. Rabies is a serious problem throughout Asia and Africa. Cases in India account for 10 to 20,000, approximately half the deaths in the world. In Canada and the United States, rabies is most commonly found in wildlife such as raccoons, skunks, and bats. So the history of animal rabies in Canada is that in 1999, raccoon rabies arrived from the United States, and rabid raccoons in Ontario, Quebec, and other provinces have been reported. Although an active eradication program was put in place, numbers of rabid raccoons have increased in Canada recently. The number of rabid raccoons ranged from 0 to 172 per year in the past decade, and depending on the year, made up 0 to 44% of positive animals tested. In some years, such as in 2016, the majority, nearly 100%, that is 171 of 172, of rabid raccoons were found in Ontario. Rabid bats and skunks are also commonly found in Canada, and in the past decade, the number of positive bats ranged from 45 to 79 bats per year, making up a fifth to half of the positive animals tested. This was also found in skunks, ranging from 22 to 115 skunks per year, with more than 15% to nearly half of the positive animals tested. Just like raccoons, many of these rabid bats and skunks are in Ontario. In fact, in some years, more than half the positive rabid bats and 3/4 of rabid skunks in Canada were from Ontario. This is the number and proportion of animal rabies cases that were identified in Canada in the past 3 years. Although, in general, the prevalence of rabies in Canadian animals is low, in 6% or lower of all animals tested, the highest number of animals that tested positive for rabies over this 3-year period were bats, and more than half of them were in Ontario. In spite of the presence of rabid animals, human rabies occurs very rarely in Canada. Only 23 people have died of rabies since 1924. Since 1985, there have only been 5 cases of rabies, all of which were fatal. Most of these cases were either from bat exposures or travel-related. The case of rabies is confirmed in the laboratory by the detection of rabies antigen using a direct fluorescence antibody test in an appropriate clinical specimen, preferably the brain or the nerves surrounding hair follicles in the nape of the neck, or isolation in cell culture in a laboratory animal of rabies virus from saliva, cerebrospinal fluid, or central nervous system tissue, or identification of a rabies neutralizing antibody titer greater or equal to 5, that's complete neutralization, in the serum or cerebrospinal fluid of an unvaccinated person. Laboratory diagnosis of rabies is performed by doing a tissue biopsy from the nape of the neck, or cerebral spinal fluid or saliva specimens are required for laboratory tests. And as mentioned on the previous slide, either a fluorescence antibody test for viral antigen or isolation in cell culture or in a laboratory animal of the rabies virus, or serological detection of rabies neutralizing antibody titers, that is 5 times or greater, that's equivalent to complete neutralization, in the serum or cerebrospinal fluid of an unvaccinated person. The rabies virus is in the Rhabdoviridae family and the Lyssavirus genus. It is a bullet-shaped enveloped single-stranded RNA virus with knob-like protrusions of glycoprotein on its surface. It is a fairly large virus in terms of its length. There's only one main serotype. However, different strains are present in different animal species. In terms of pathogenesis, the rabies virus replicates in muscle tissue at the site of inoculation, then enters the nervous system, spreading through the central nervous system to the salivary and adrenal glands, kidney, and lungs, and replicating exclusively in gray matter. The rabies virus forms Negri bodies, which are eosinophilic cytoplasmic inclusions, filled with virus nucleocapsids that can be found throughout the brain and in infected nerve cells. In response to any potential rabies exposure, post-exposure prophylaxis should be administered. This includes passive immunization with hyperimmunoglobulins called Rab-IG, together with active immunization with anti-rabies vaccines, which consists of the inactivated attenuated rabies virus. 4 doses should be given on days 0, 3, a week, and 2 weeks after exposure. Another dose is given a month later for immunocompromised individuals or those on anti-malarial medication. As mentioned on the previous slide, the rabies vaccine is the inactivated virus, and unlike for post-exposure prophylaxis, only 3 doses are required, given on day 0, a week later, and any time between days 21 to 28. The rabies immunoglobulin, Rab-IG, is administered during post-exposure prophylaxis and is part of the passive immunization process to provide neutralizing antibodies as quickly as possible to someone who has been exposed to the virus so as to prevent the development of the disease. 20 international units per kilogram of body weight is given to all age groups, including children, given on the first day of therapy initiation and infiltrating the wound and surrounding areas thoroughly. There is a provincial rabies protocol in Ontario. It is actually one of the few protocols for any communicable disease that is in existence, so I need to go over it with you. If you've already heard about it in another course, I may skip this part of the lecture so you can go over it on your own. It is the responsibility of the Public Health Unit to provide the rabies post-exposure prophylaxis, that is the vaccine and Rab-IG, on a contingency basis to institutions. This includes storage and delivery to hospitals and clinics. Cases receiving post-exposure prophylaxis or PEP should also be reported to Public Health Ontario and the Ministry of Health and Long-Term Care, as well as entered into the Integrated Public Health Information System, or IFIS. The Ontario Health Protection and Promotion Act has a regulation 5557 under Communicable Diseases General, which stipulates that any healthcare provider or person, such as a doctor, veterinarian, or police officer, who has information concerning any animal bite or other animal contact that may result in rabies in persons, shall as soon as possible notify the medical officer of health with the information. All related animal-to-human exposure calls or inquiries need to be documented and investigated by public health. The victim and animal owner must be contacted within 24 hours of notification, after which a letter must be hand-delivered. Data should be collected on the exposed person, exposure incident, and animal, as well as the owner of the animal. A risk assessment needs to be carried out on the exposed person to determine their post-exposure prophylaxis requirements. This includes the type of exposure, that is, bite, non-bite, or bat, anatomical location of exposure, risk of rabies in the animal species involved, presence of rabies in the area where the incident occurred, and the risk of rabies exposure in the implicated animal, such as the travel history and exposure to wildlife or other domestic animals of unknown rabies status. Other information required includes behavior and health status of the implicated animal, exposure circumstances, whether the exposure was a bite that was provoked or unprovoked, and rabies immunization status of the animal or the animal's mother if the animal is a puppy or kitten less than 3 months old. The risk assessment conclusion should be provided to the attending physician, who makes the ultimate decision regarding provision of post-exposure prophylaxis. Individuals must have access to post-exposure prophylaxis within 24 hours. The implicated animal needs to be confined and isolated from all other animals and persons, except the person caring for the animal, during a 10-day minimum observation period from day 0 of exposure, and the vaccine status of the animal involved in the incident needs to be checked. The nearest CFIA district veterinarian and Public Health Ontario veterinarian needs to be notified as soon as possible if the animal is believed to be rabid. So the different types of exposure. These are bites, where there is any penetration of the skin by teeth, or non-bites, which include scratches, abrasions, or cuts on the skin, or mucous membranes by saliva, or other potentially infectious materials such as brain tissue, and also bat exposures where PEP is recommended. When a bat bite or scratch has occurred, or when there's direct contact with a bat that is visibly seen, and either of the following cannot be eliminated, a bat bite or scratch or saliva from a live bat that has entered an open wound or mucous membranes. Recommendation of PEP or post-exposure prophylaxis is determined on a case-by-case basis, which can make it subjective and also difficult for those making the decision. There are several algorithms which can be followed, published by the Public Health Ontario as well as the Ontario Ministry of Health, to help the decision-making process more objective. I've provided the links at the bottom of this slide. As you can see, there are a list of questions that need to be asked, and the information gathered that needs to be used to decide on subsequent interventions. All the questions are highly pertinent, but the second question on where the bite is located is particularly important because the closer it is to the neck area, the faster the viral infection will spread and symptoms will present, after which the chances of having any success with post-exposure prophylaxis will be reduced, and the outcome will likely be a fatal one. Provocation of the biting animal is also important because most animals will bite even when they're not rabid if their space has been invaded. Once an animal is infected with rabies, they may bite without any provocation, so it is an important piece of information to obtain from the person with the exposure. When bites on the face, head, and neck are severe, prophylaxis should be started immediately before the 24-hour period, as the incubation period will be very short, less than a week, so there's no time to wait for laboratory test results or the observation period of 10 days. PEP should not be delayed, especially if rabies exposure is considered likely, such as in a location where rabies is endemic. In other circumstances, initiation of prophylaxis can be delayed through the 10-day animal observation period in an area with low rabies prevalence if the animal is a domestic pet that is fully vaccinated and the bite was provoked. However, post-exposure prophylaxis should be initiated if the animal shows signs of rabies. Treatment may also be withheld until the immunofluorescence test result is available. If the animal specimen is received at the lab within 48 hours of exposure and the vaccine administration discontinued after consultation with public health or infectious disease experts if the fluorescence test results are negative. Due to these various scenarios that may present themselves when dealing with a potential case of rabies, I've added some examples on the next few slides to help with the PEP recommendations. I'll take a poll to see what everyone thinks the decisions should be. In the first scenario, a man was jogging in his neighborhood and runs past a house where the family dog is leashed to a fence. He gets too close and the dog bites him on the leg. He seeks care from his family physician, who wonders about the need for rabies PEP and contacts the local public health unit. The case is referred to you. What will your advice be? In this case, the jogger may have provoked the dog by getting too close, causing the dog to bite him. The dog, a domestic pet, can be observed for 10 days. If it doesn't show any signs of rabies, then the jogger does not need PEP. The 10-day observation period comes from studies showing that dogs, cats, or ferrets that are infected and contagious for rabies will show clinical signs within 10 days of an exposure. If this occurs, PEP should be started immediately. The animal should then be euthanized and sent for confirmatory testing. In the second scenario, a young girl is sitting on a park bench with her mother on a warm summer day. All of a sudden, she feels pain in her lower leg and notices that a raccoon has bitten her. Startled, she yells out in pain and the raccoon runs away. She's taken to the emergency department for treatment, and the physician on duty wonders about the need for rabies post-exposure prophylaxis. He calls a local public health unit for advice. The case is referred to you. What will your advice be? In this case, the girl was the subject of an unprovoked attack by a wild animal. These two features create a high-risk scenario for rabies exposure. Unless the wild animal is caught and tested definitively for the presence of rabies virus, PEP should be given to these cases. In scenario 3, a woman wakes up at her cottage one morning and finds a bat in her bedroom. She chases it out of the cottage and mentions the story to her neighbor. Her neighbor recalls reading something about bats and rabies and suggests that she discuss the issue with her family physician. The family physician calls the local public health unit. The case is referred to you. What will your advice be? This case deals with an unattended exposure to bats. Bites and scratches from bats can be very minor and often go undetected if they occur while the person is sleeping. PEP is recommended only when there is direct contact with the bat, and either a bat bite, scratch, saliva from a live bat has entered an open wound or mucous membranes. Otherwise, PEP is no longer recommended. If it's possible to isolate the bat, it can be sent to the lab for rabies testing, so that if PEP is initiated, it can be stopped in the event of a negative result. However, caution should be used when coming in close contact with the bat, as this may inadvertently result in a bite or more direct contact with bat saliva. So the best course of action is to call wildlife or animal control services to capture the bat, and the worker needs to wear PPE such as thick leather gloves and avoid touching the bat. The intact bat should be placed in a closed, secure container before shipping off for testing. The fourth scenario is a real-life event that occurred in Toronto in 2008. A Toronto Humane Society supervisor was bitten by a puppy that was brought to the shelter by a family residing in Peel region. The puppy became ill a day after it was purchased from a pet booth at Dr. Flea's flea market. The puppy dies and is tested. It is positive for rabies. What should the clinical, occupational, and public health response be? In this case, the shelter supervisor receives PEP immediately. A fact sheet was released as part of the public health alert with background information on the infected animal so that exposed individuals are aware of the risk, exposure history details on littermates, and the puppy's mother who died on the breeder's farm in Perth County after exposure to a rabid skunk, and the supplier and vendor details on the remaining puppies that were picked up by a supplier in Chesley, Ontario, and sold at the Toronto flea market. Health unit contact information was also provided to all exposed individuals to get further advice with brief information on rabies, its transmission, risk factors, and incidence in Canada. Generally, most cases of rabies will die, and treatment, aside from PEP, even though it can be initiated, is still considered to be controversial and experimental, as there is a low success rate. This treatment is called the Milwaukee Protocol. The exposed person who is showing clinical signs of rabies is put in a chemically induced coma, and the antiviral drugs amantadine and ribavirin administered. The clearance of virus is dependent on the host immune system. Only 10 people have survived this treatment. The first was an American girl who was bitten by a bat and waited a few weeks before seeking medical attention. Last time I checked, she had finished high school, then college. Now she's a mom. Rabies can be prevented by immunizing pets, reporting aggressive animals, or animals that have bitten people to the police, not handling animals that are acting strangely or are sick. not keeping wild animals as pets, and administration of the rabies vaccine to those who are at high risk of exposure. To prevent rabies in workers, immunization is recommended for laboratory workers who handle the rabies virus, veterinarians, veterinary staff, animal control, wildlife and park workers, hunters and trappers in areas with confirmed rabies, spelunkers, that's people who have caving activities, and travelers to rabies endemic countries.